Bismillahirrahmanirrahim. So today we are going to start with the musculoskeletal system. So let's get straight into it. Anatomy and physiology. So anatomy and physiology, back and autonomic nervous system. So lumbar puncture, tap, and epidural anesthesia. This is the picture from the 100 points. We have already recorded a playlist, not a playlist per se, but the videos on the 100 points. So go check that out. So when a lumbar puncture is performed, the needle enters the subarachnoid space to extract the cerebrospinal fluid, that is spinal tap, or inject the anesthesia, that is spinal block, or contrast material. Okay, the needle is usually inserted between the L3 L4 or L4 L5 level of the horizontal line through the upper points of the iliac crest. Suppose that these are the, so there's not a picture of that, so suppose that this is the upper point of iliac crest over here, superior spine, and over here, and there's the highest point over here. So we join both the lines together, so they will pass through the L4 L5 vertebral level. So yeah, so mostly we join that line and then we pass a needle into that. The spinal cord ends at as low as L2 in the adults and in the L3 in the young children, and the needle sac extends caudally to the level of S2. Before the procedure, the patient should be examined for the signs of increased intracranial pressure because cerebellar tonsils may herniate to the foramen magnum. Because firstly we have to check if there is increased intracranial pressure or not. If we if we see the signs of raised intracranial pressure in the patient, that is, maybe the patient is having severe headache, or maybe the patient is having papilledema, or there is some visual impairment or something like that. If there is any sign of increased intracranial pressure, we are not supposed to do the lumbar puncture, because in that case, whenever we insert the needle, there will be a gush of cerebrospinal fluid coming out of the puncture needle, and there is a chance of cerebellar tonsils to herniate downwards that can also prove fatal. The internal vertebral venous plexus epidural space is valveless and connects the veins of the pelvis, abdomen, and thorax. It provides a route for metastasis of the cancer through the vertebral column, cancer cells to the vertebral column and the cranial cavity. For example, from the prostatic plexus is in direct communication with the vertebral plexus. So the cancer from the prostate can go all the way to the vertebral vessels and then all the way to the brain. So here you can see there is they have shown the picture. Will go in a clockwise fashion. So in epidural space, then we have the vertebral body. This is the vertebral body. Then epidural fat is present over inside the epidural space. Then we have subarachnoid space, that is below the below the arachnoid matter. Yeah, so here is the arachnoid matter, and below that we have subarachnoid space. Here we have the dura mater, and below the dura mater we are having above the dura mater we are having epidural space. Then the pia mater is the deepest structure, like that is in intimate contact with the spinal cord. Then we have intervertebral foramen, that I have the denticulate ligament, then the internal vertebral venous plexus, the dorsal root of the spinal nerve, then spinal nerve is over there, and ventral root of the spinal nerve is over there. So you can see this picture. Then these are the layers which are being pierced whenever we enter the noodles. So remember that for the epidural anesthesia, we have to go only till epidural space. So we will be piercing the skin, the subcutaneous fascia. Then there will be there are two ligaments per se. Okay, so then I have not drawn that, and then ligament of flavum, and after that we are into the epidural space. That's it. We are not supposed to go any deeper for the epidural anesthesia, but for the lumbar puncture, we have to pierce the skin, then subcutaneous fascia, then the ligament of flavum. Then after that we have to pierce the laminae as well, and then the epidural space. We have to go through the epidural space into that. We have to also puncture the arachnoid matter to enter the subarachnoid space that contains the CSF, right? So then we have in the next picture herniated disc. So what is the concept of herniated disc? The herniated disc usually occur in the lumbar L4, L5 or L5 to S1 or cervical lesion C5 to C6 or C6 to C7 of the individuals younger than age 50. Herniation may follow the degenerative changes in the annulus fibrosus and can be caused by sudden compression of the nucleus pulposus. The IV disc generally herniates posterolaterally due to their posterior longitudinal ligament and thicker anterior longitudinal ligament along the midline of the vertebral bodies. Herniated lumbar disc usually involve the nerve root of one number below traversing root. For example, the herniated L4 L5 will compress the L5 root. Present with a radicular pain and weakness. Diagnosed clinically with a straight leg raise test. Positive if the pain when knee is extended. Positive if pain when knee extended, hip is flexed 30 to 70 degrees, and ipsilateral pain probably no herniation. Contralateral pain probably herniation with MRI. So these are some tests which are like written in some Greek language. I cannot understand that. So ipsilateral pain, probably no herniation. So if there is ipsilateral pain radiation, so probably there is no herniation. And if it is, the pain is radiating contralaterally, so there is probability of herniation, and confirmed with MRI. So here you can see the ventral view, anterior longitudinal ligament, then you have the posterior longitudinal ligament. The posterior lateral herniation is common. IV disc generally herniate posterior lateral due to the posterior longitudinal ligament, due to the thin posterior lateral ligament, posterior longitudinal ligament, and a thicker anterior longitudinal ligament. So anterior one is thicker, while the posterior longitudinal ligament is thinner. Then we have annulus fibrosus and the nucleus pulposus. So the nucleus pulposus will be herniating outside. That is the concept of disc herniation. So here you can see the herniated disc at this level. So fourth number vertebra, fourth number spinal nerve is over there, compresses the. Then here we can see the nucleus pulposus, and in this picture the nucleus pulposus is herniating outside into the vertebral canal. Okay, and the herniated intervertebral disc is over there. In this picture you can see that intervertebral foramen. So they are highlighting the intervertebral foramen. What's meant by that? So intervertebral foramen is a space, like this is intervertebral disc, this is a vertebra, and between the two vertebra we have intervertebral disc. Okay, then this particular thing is called pedicle, and then that is zygapophyseal joint. Okay, then we have spinal nerve over there, and posterior longitudinal ligament is behind that. That is a thin ligament, so there is a possibility of herniation from this side. What's the point of intervertebral foramen? I guess this is intervertebral foramen from which the nerve roots come out. I guess this one. Okay, moving forward. Now let's talk about abnormal curvature. Abnormal curvature of the spine. So abnormal curvatures include lordosis of the lumbar region, kyphosis of the thoracic region, and then we have scoliosis. That is a totally different thing. So kyphosis is an exaggeration of the thoracic curvature that may occur in the elderly person as a result of osteoporosis, multiple compression fractures of vertebral bodies, or disc degeneration, and specifically in the thoracic region. What is lordosis? It is an exaggeration of the lumbar curvature that may be temporary and occur as a result of pregnancy, spondylolisthesis, or port belly. Scoliosis is a complex of lateral deviation of torsion that is caused by poliomyelitis, a leg length discrepancy, that is one leg is shorter than the other, or a hip disease. So these things can happen. So you can see compensatory curve of the cervicothoracic region. So primary scoliosis was in the thoracolumbar region, and to compensate that there was a curvature of cervical spine into the opposite region. So it was like that, and it went like that. So there's an S-shaped configuration, an opposite S maybe, an inverted S-shaped configuration of the spine. So that thing is called as scoliosis. Now what is caudal regression syndrome? Patients are born with the agenesis of the sacrum and occasionally lumbar spine. That is called as caudal regression. It is frequently related to poorly controlled maternal diabetes presentation, flaccid paralysis of legs, dorsiflex contracture of the feet, urinary incontinence, and range in severity from isolated anal atresia to cyanomelia. What is cyanomelia? Let me check that. So cyanomelia, Mermaid syndrome is a rare congenital fetal anomaly with characteristic feature of a complete or partial fusion of the lower limbs. Although this syndrome is incompatible with life due to the association of severe congenital visceral abnormalities, however, there are few reports of surviving infants. So here you can see cyanomelia. It is called as mermaid syndrome. So children are looking like this, but in most of the cases it is not consistent with life. Moving back, so then we have like spinal stenosis, abnormal narrowing of the spinal canal occurring most commonly in the lumbar region, caused by degenerative arthritis of the spine, especially in the patients more than 60. Intervertebral disc shrinks, and that narrows the foramen. Facet joint arthritis leads to bone spurs. Ligamentum flavum is hypertrophied. So intervertebral disc shrinks leads to narrowing of the foramen. Facet joint arthritis leads to bone spur. Facet joint arthritis causes the formation of bone spurs, I guess, and ligamentum flavum is hypertrophied in the case of spinal stenosis. Okay, clinical picture. I guess these are the causative factors. Number one is intervertebral disc shrinkage. Number two is facet joint arthritis, and number three is ligamentum flavum hypertrophy. I guess these are the things which are causing the spinal canal, narrowing, spinal stenosis. So clinical picture. Compression of the nerve roots result in the lower extremity pain, numbness, paresthesia, and weakness, pain with walking, neurogenic claudications, mimics the vascular claudications, but in neurogenic claudication, the pain persists with the rest when starting when standing and improves with the stooped or flexed position. So the okay, so persists with rest. So basically, when there is vascular claudication, so in that case, the pain occurs when the person is doing some physical activity and is relieved as soon as the person starts doing the rest. But in the case of neurogenic claudications, so the pain is not relieved by rest, and secondly, the pain is there when the person is standing straight and improves when the person is stooped or in flexed position. The pain is posture dependent. Extension of the lumbar spine, for example, standing, walking upright, further narrows the spinal canal, worsening the symptoms, and lumbar flexion, for example, walking uphill, leaning on the stroller or shopping cart sign, that relieves the pain. So the women who will do the shopping while having the shopping cart in the hand, the person is stooped forward. So in that stooping posture, the spinal canal that is previously stenosed becomes a bit patent and the pain is relieved. But when the person is standing straight, the pain is severe. Symptoms worsen with the lumbar extension and leaning forward relieve the pressure, lessening the symptoms. Then let's talk about the ligamentum flava. What's meant by that? So paired elastic ligaments that connect the vertebral laminae. So ligamentum flavum, here you can see thickened ligamentum flavum. It is the thickening of the ligamentum flavum, and this is a normal ligamentum flavum over here. So if it is thickened, so it will cause a compression of the spinal canal. Spinal canal is basically the space in which we have the spinal cord, right? In the vertebral bodies, the space which houses the spinal cord is called as the spinal canal. Now these are the causative factors which can cause this thing, which can cause spinal stenosis. So here you can see that normally the ligamentum flavum is like this structure. If it becomes hypertrophied, so it will look something like that. So if it is becoming this large, so it will cause hypertrophy. If it is hypertrophied to this extent, it will cause stenosis of the spinal canal. Secondly, this thing is called as a facet. Hypertrophied facet or an osteophyte formation. So if there is some, this thing is called as osteophyte, or there is another name to that. If there is bone spur, bony spur. Facet joint arthritis or bone spurs are formed if there is osteophyte or bony spur formation that is extending inward. That will, okay, give me a second. That is extending inward, that will also be compressing the spinal canal. And the third thing about it was, there was another thing. They were saying that intervertebral disc shrinks. So intervertebral disc shrinkage. Ligamentum flavum is over there and spinal segment. So even if the intervertebral disc shrinks, so that also leads to the shrinkage of the stenosis of the vertebral canal. So we are talking about the ligamentum flavum. So what is meant by that? The ligamentum flavum, the paired elastic ligaments that connect the vertebral laminae, they form the posterior wall of the spinal canal and help hold the body erect. Okay. So here you can see these are some ligaments of the spinal canal or the vertebral body. So this is anterior longitudinal ligament over here. Just give me a second. Yep. We have anterior longitudinal ligament. Then we have the ligamentum flavum that is present inside here. Then there is supraspinous ligament outside this. Then interspinous ligament that is connecting the two spines. Posterior longitudinal ligament, which is opposite to that of the anterior longitudinal ligament. The counterpart of that, the posterior counterpart of that. Then facets, capsular ligament, and the intertransverse ligament. So there are a lot of ligaments. Remember the difference. Remember that you must be able to differentiate between the anterior and posterior. Anterior one is thick, posterior is thin, so that most of the disc herniations are happening posteriorly. Secondly, the ligamentum flavum, if it becomes hypertrophied, so it can cause a spinal canal stenosis. So these are the two things that you must remember. And if you are like very good in studies, so remember all the ligament names. Now we'll move towards upper limb. So 0 to 15 degree abduction is mediated by the supraspinatus muscle. The nerve supply is by suprascapular nerve. 15 to 100 degree abduction is mediated by the deltoid muscle. The nerve supply is axillary nerve. More than 90 degree, like it is 15 to 100 by deltoid, but normally we say that to move above 90 degree, we need trapezius muscle, and it is supplied by the accessory cranial nerve, that is CN11 nerve. Then to move above 100 degree, we need serratus anterior, and serratus anterior is supplied by the long thoracic nerve. So there is a mnemonic for that, that is SALT. Serratus anterior is supplied by the long thoracic nerve. Good mnemonic. So now let's move forward. Here you can see rotator cuff muscles. Rotator cuff muscles innervated primarily by the C5 and C6 nerve root. So basically it is innervated by the nerves that are originating from the C5 C6 nerve root. Support the shoulder joint by forming the musculotendinous rotator cuff around it, reinforcing the joint on all the sides except inferiorly, where this location is most likely. So here you can see that these muscles are joining the joint capsule over here. That's a good picture. So these muscles, these are sits muscle. They are suppose this is the glenoid tubercle. It's not glenoid tubercle, but this is the this is called a glenoid humeral joint. So this is glenoid labrum over here, and here the humeral head, something like that. So these muscles are attached. They are attached to the humeral head in such a way that they are attached from all the directions, superiorly, laterally, and medially. That they are pulling the humeral head towards the scapula, so that the glenohumeral joint is not displaced or the humerus is not dislocated. But these muscles or any such attachment is not present inferiorly. So the inferior side is weakest side. So the humerus has a chance to move inferiorly or to be dislocated inferiorly. So most of the humeral dislocations are occurring on the inferior side. So they draw the humerus head into the glenoid during the abduction. Okay, so when we are doing the abduction, so they hold the humeral head together so that it is not dislocated. Tendinitis, pain with abduction. Tears, inability to abduct. So we'll talk about this one. So here you can see that these are the sits muscles and this is the configuration in which they are present. So on the greater tubercle we have three muscles that are sit. So these are supraspinatus, infraspinatus, and teres minor muscle. All of the three muscles which are attaching on the greater tubercle, they are arising from the posterior surface of the scapula, like on the back, supraspinatus, infraspinatus, and teres minor. But the one that is attached to the lesser tubercle, that is originating from the costal or the anterior surface of the scapula, and okay, then we have, and that is attached to the lesser tubercle. Got it? So then we have intertubercular groove between the two tubercles. Okay. Then in the rotator cuff, okay, so we were talking about tendinitis. What is tendinitis? The muscle tendon of the supraspinatus muscle, suppose now I will use this diagram. So the supraspinatus muscle, which is over here, it is present on the if scapula looks something like this on the back, something like this and this, and here we have scapular spine. This is the lateral. So scapular spine looks something like this. Okay. So the supraspinatus muscle is originating from here, right? As you can see there. So supraspinatus muscle goes all the way below the acromion process and is inserted on the greater tubercle. So the tendon is present between the acromion, that is the bony projection, and the humerus. So to protect it from the infection, or not infection per se, to protect it from the friction that it can confer against the acromion bone, there is a bursa present between them, that is called as acromial bursa. In case there is excessive friction or there is tendon rupture, that is called as tendon tear. So if there is tendon tear, so there will be inability to abduct. Or if there is tendinitis, or there is inflammation of the tendon or inflammation of the bursa, that is bursitis, in any of the two conditions there will be pain with that. So they are talking about that. But you must also remember that for any muscle that is responsible for the abduction, if there is if the tendon of that muscle is inflamed, so resultantly we can have some problem, either pain or total inability to abduct. In the rotator cuff syndrome, the most commonly injured tendon is that of the supraspinatus, as this tendon is prone to repeated impingement trauma between the humeral head and the acromion, as shown by the arrow over here, especially in abduction, assessed by empty or full can test. So there are empty or full can tests. I guess there was some description of that in the there was some description in the 100 points. So go check that out. So because there was some maneuver, so if not, so do you check some animation or some video on the YouTube, you will find some. So but we do the empty or full can test for this one. Then these are the rotator cuff muscles. So this is a picture from Uworld, and this is a table from Uworld basically. So let's see that. So we're talking about supraspinatus, infraspinatus, teres minor, and the subscapularis muscle. Supraspinatus, origin of the scapula is supraspinous fossa. Okay, attachment is greater tuberosity of the humerus. Function is abduction, or you may say that initiation of the abduction up to 15 degrees, and innervation suprascapular nerve. Okay, so supraspinatus is being supplied with the suprascapular nerve. We will see the origin of that when we study the brachial plexus after a few pages, inshallah. Then we have infraspinatus muscle. Infraspinatus muscle, the origin of the scapula is from the infraspinous fossa. Attachment of humerus is the greater tuberosity. So these three muscles are on the greater tuberosity. Then function on the arm is external rotation. Okay, innervation is suprascapular nerve. So this is also supplied by both supraspinatus and infraspinatus are being supplied by the suprascapular nerve. Okay, then we have teres minor muscle. It is originating from the lateral border of scapula. Attachment on the humerus is at the greater tuberosity. Function on the arm is adduction. Remember, it is the adductor and external rotation. So adduction and external rotation. Innervation is by the axillary nerve. Subscapular nerve, subscapularis muscle. Origin of the scapula is by the subscapular fossa. Okay, subscapular fossa is on the anterior aspect of the scapula. Attachment of the humerus to the lesser tuberosity. Function of the arm, adduction and internal rotation. And innervation is by the upper and lower subscapular nerve. So here you can see this is acromion clavicular joint. So there are some anatomical pictures. So here we have clavicle, and the joint between the acromion of the scapula and the clavicle bone is the acromion clavicular joint. And then we have supraspinatus tendon, and between the supraspinatus tendon and the acromion we have this subdeltoid bursa. Okay, that is called subdeltoid bursa. Then we have deltoid muscle over there. Then here you can see the acromion, and then supraspinatus, and this is supraspinatus muscle. This is infraspinatus. This is biceps tendon, subscapularis, teres minor. The inferior is kind of devoid. You may say that the inferior surface is somewhat devoid, and here we are posterior on the posterior side. So the infraspinatus and the teres minor on the posterior surface, and the supraspinatus is like a kind of superior, and subscapularis is on the anterior surface. So stuff like that. And then here you can see that this is the humerus and this is the glenoid, and this thing is called as glenohumeral joint. Moving forward, we'll see that musculoskeletal empty cantus. How do we do that? Patients abduct the arm to 90 degree, flex the arm to 30 degree, point thumb down towards the ground as if pouring out a can. So if I could draw that, suppose this is our man, and he is asked to abduct the arm to 90 degree first. Then he was asked to flex the arm to 30 degrees, so he was moving his arm forward by 30 degrees, and then he was pushing his thumb downwards. So this is the hand, and he was having his thumb downwards. So 90 degree abduction and then 30 degree flexion, that is moving the arm 30 degree forward, and then moving the hand or thumb downwards, that is empty can test, resisting examiner's downward force. So now the examiner is pushing downward and that man of ours is resisting. So unilateral pain and weakness will be there in the case of tendinitis, 90% specific for supraspinatus pathology. Okay, then these are the important muscles. So here you can see this is the deltoid A. Deltoid action is arm abduction. So main abductor of the arm is the deltoid muscle, and innervation is by the axillary nerve. Okay, there was another muscle that was being supplied by the axillary nerve, that was over here, that is teres minor. Okay, then we have trapezius. So trapezius muscle is over here, this triangular muscle. It goes like this and all the way this, and this is a very long muscle. So this is trapezius. Elevate, rotate and stabilize the scapula. It is supplied by the accessory cranial nerve. The tricep muscle, it extension of the elbow. Okay, and it is supplied by the radial nerve. So tricep is supplied by the radial nerve, deltoid by the axillary nerve, and the trapezius by the accessory muscle, or not accessory muscle, accessory cranial nerve. Then we'll talk about latissimus dorsi. So latissimus dorsi, the large thoracolumbar muscle that contributes to the forceful movement of the humerus, vulnerable to injury by the external trauma due to broad area and exposed location. It is also frequently injured in sports requiring the forceful downward movement of the humerus, such as throwing, climbing, or swinging the tennis racket overhead. Origin: it originates in a broad area spanning from the iliac crest and the lumbar fascia to spinous process of T7 to 12 and the lower ribs. Insertion: it inserts at the bicipital groove of the humerus. Okay, it inserts at the bicipital groove. And innervation: thoracodorsal nerve with a fiber originating from C6 to CA2. So remember the thoracodorsal nerve. For the latissimus dorsi, we have innervation coming from the thoracodorsal nerve. Function: extension, adduction, and the internal rotation of the humerus. Okay. Then we have subacromial bursitis, often due to the calcific supraspinatus tendinitis, causing painful arc abduction. Okay, painful arc of abduction. Arc of abduction means that if this is me standing, and this is my arm downwards. So the total arc of abduction, all moving of my arm all the way up here, that is the arc of abduction. So in the case of a subacromial bursitis, the arc of abduction will be painful. So here you can see this is the bursa, and I don't think it is named in this picture, but the bursa is present over here. Overuse injuries of the elbow. Medial epicondylitis. So medial epicondyle, suppose this is the humerus, this is the head of the humerus, then we have humerus going down, and the distal end of the humerus is looking like this, something like this. On the medial side we have medial epicondyle, on the lateral side we have lateral epicondyle. So on the medial side we have the flexor attachment, and on the lateral side we have a common tendinous attachment of the extensor. So now we are talking about the medial epicondylitis or the golfer's elbow. Repetitive flexion, forehead shorts or idiopathic pain near the medial epicondyle. Repetitive flexion, forehead shorts or idiopathic that will lead to pain near the medial epicondyle. The lateral epicondylitis or tennis blow. So a person who plays the golf, he has this thing that is called medial epicondylitis, and for the person who is playing tennis, he will have tennis elbow or lateral epicondylitis, repetitive extension, backward shorts or idiopathic, that leads to pain in the lateral epicondyle, that is called lateral epicondylitis, because the extensor muscles have a swollen extended tension, common tendinous attachment at the lateral epicondyle of the humerus. So you can see that in zoom view. These are extensor muscles, swollen extensor, and the lateral epicondyle of the humerus is painful. Then we have uniulnar collateral ligament injury. Okay, so we know that ulna and radius, they are attached to the humerus, right? The ulna is articulating with the on the medial side, while the radius is articulating on the lateral side. So the ligament that is connecting the medial epicondyle with the ulna is called as the ulnar collateral ligament. Over here, it is present on the medial side. If there is a tear to that, so we'll see what happens. It connects the medial epicondyle to the ulna. Occurs most commonly in the throwers, for example, the baseball pitcher, due to the intense valgus stress on the elbow. Valgus means, I guess, outward motion of the arm. That is called valgus stress. Okay, so treatment often involves the ulnar collateral ligament reconstruction, that is Tommy John's surgery. Now we are up to the brachial plexus. So let me open this one. So the very first thing that you must remember about the brachial plexus is this sequence, like roots, trunks, division, cord, and the terminal branches. So how to remember that? So to remember this, there was a mnemonic by that very good channel, Ninja Nerd. Yeah. So the mnemonic is, let me write it over here. It will take some time. So the mnemonic is, remember to drink cool beer. So this is roots first, then trunks, division, cords, and terminal branches. And there's another thing about brachial plexus that you must remember, that the brachial plexus originate from the roots which are in the from the spinal roots. So the very first confusing thing in this is, we have 7 cervical vertebrae, right? But there are C8 segment of the brachial plexus. As you can see in this picture, this is a C8 segment. Although there is no C8 cervical vertebra, but there is C8 root of the brachial plexus, so it is sometimes becomes confusing. So REM to drink cool beer. Okay, so until it is writing that, my text one is slower, so that is why I use my pencil. So here you can see, remember to drink cool beer, that is the mnemonic. R is for the roots, then T is for the trunks, then D is for the divisions, C is for the cords, and T is for the B is for the terminal branches. So first confusing thing is this C8 vertebra. Secondly, you must remember another thing, that the brachial plexus first joins, then divides, then joins, and then divide again. So this is the sequence. Like firstly, the roots will join to form trunks, and they will divide, and then again they will join, and then again they will divide. So there is a lot of joining and division and joining and separation happening over there. So now let's see it over here. It is a picture of Kaplan. So if you want to understand it thoroughly, I will try to explain as much as I could, but for thorough understanding, you must listen to the Ninja Nerd video and also to the Ekland videos. They're like super videos on this. So let's see this. Now here you can see that C5, C6, C7, C8, and T1 are the root values from which the brachial plexus is originating. Now, firstly, the upper 2 roots and the lower 2 roots, they will join together to form superior and inferior trunks, while the middle root, that is C7, that will mind its own business and it will not join with anyone, and that is called as the middle trunk. Remember this thing. So what happened, that the upper 2 roots, these two, and the lower 2 roots, they join together to form superior and inferior trunk respectively, while the C7 nerve root did not join with anyone, and that formed middle trunk. Okay, then all the 3 trunks, they divided into anterior and posterior cords, divisions. I'm sorry. So all the 3 trunks, superior, middle, and inferior, they divided into superior, anterior, and posterior divisions, right? All the 3 trunks, which are superior, middle, and inferior, they were subdivided into anterior and posterior divisions. Like here you can see anterior and posterior division of the superior trunk. Here is the anterior and posterior division of the middle trunk, and anterior and posterior division of the inferior trunk. Now, all the 3 posterior divisions will join together to form the posterior cord, right? I hope that it is clear, very clear, that all the 3 posterior cords from all the 3 trunks, they will join together to form the posterior cord. The anterior division of the superior and middle, they will join together to form the lateral cord, while the anterior division of the inferior cord will not join with anyone, and that will form the medial cord. So I will revise up till here that firstly C5, C6, C7, C8 and T1, these were the root values that were emerging out, and these are anterior roots basically, because spinal cord, if there is a spinal cord over here, spinal cord, so there's a butterfly inside that, and the posterior roots or the dorsal roots, they are basically for the sensory purposes, and if we are talking the brachial plexus nerves are motor nerves, so they are definitely emerging from the ventral roots. So these are ventral roots. So these are ventral roots of C5, 6, 7, 8 and T1. Now these ventral roots, they will emerge and they will join together to form trunks. The first two will join together to form the superior trunk. The bottom two will join together to form the inferior trunk, while the middle C7 that will not join with anyone to form the middle trunk. All the three trunks, they will subdivide to form the anterior and posterior divisions. All the three posterior divisions originating from three trunks, they will join together to form the posterior cord. The anterior division of superior and middle trunks, they will join to form lateral cord, while the anterior division of the inferior trunk will not join with anything, and that will form the medial cord. Okay, so this is the concept of cord. Now, the posterior cord, which was formed by the fusion of three posterior divisions, that will give rise to axillary and the radial nerves. The lateral cord will give rise to musculocutaneous branch, like we are now talking about terminal branches, and the medial cord will give rise to ulnar branch. The lateral and medial together will give contributions to form the median nerve. Now, here you can see that we have a formation of an M. This M formation is for musculocutaneous, median and the ulnar nerve, which is formed over here. So this is the basic concept of brachial plexus. Now, in this basic concept, we will have some, these are the basic, this is the basic roadmap, and now we have further subdivisions and a lot of nerves which will be originating either from the cords or from the trunks. There is no nerve that is originating from the division. Some nerves are originating from the cords, and then we have the terminal branches. So we'll see the branches that are coming out of the roots, then the ones which are coming out of the trunks, then the ones which are coming out of the cords, and we have already seen the terminal branches. So starting from the roots. Now the nerves that are originating from the roots include the dorsal scapular nerve that is originating, that is a very long course of origin, as you can see here, that it is originating, no, it does not have a long course, it is originating only from the C5 nerve. The dorsal scapular nerve is this one. Okay, I was confusing it with the long thoracic nerve. So there are two nerves that are originating directly from the roots. The first one is dorsal scapular nerve, and the second one is long thoracic nerve. The dorsal scapular nerve provides the innervation to the rhomboids, which are rhomboids major and rhomboid minor, and also the levator scapulae, the levator scapulae muscle. These are being supplied by the dorsal scapular nerve. Okay. Then from the C5, C6 and C7, there is a nerve that is originating, that is called as long thoracic nerve, and this long thoracic nerve is supplying the serratus anterior muscle. I hope it is clear. There was a muscle that was thoracodorsal. Give me a second. There was a muscle that was being supplied with thoracodorsal. So thoracodorsal nerve can also supply the latissimus dorsi. So here I have written serratus anterior, and therefore long thoracic, by the way. So I was confusing that. So thoracodorsal is different nerve. We'll see that when it originates. So long thoracic nerve is supplying the serratus anterior muscle, while the dorsal scapular nerve is supplying the rhomboids and levator scapulae. Now there is a footnote. Remember that you are not supposed to remember all these muscles and all these innervations and all that. Remember only what is written in the first aid for the anatomy, and all that is present in the Uworld. Okay, because there is a lot of knowledge about anatomy, a lot of junk knowledge. I'm sorry to say, but there is a lot of junk knowledge. You're not supposed to remember these things, because you're definitely supposed to forget them a few days after listening to them or after reading them. So I'm speaking that for the sake of completion. Listen to it, remember as much as you can comfortably remember from the basic knowledge which you had when you read anatomy for the first time. If you don't have it, so that's not a big deal. We'll move on with that without having all of these crap knowledge, and just listen to it and remember whatever is written in the first aid. So this is picture on the KLM, it is not on the first aid. I've just brought this picture just for the sake of explanation. Moving forward to the nerves that are originating from the trunks. Now there is only one, I guess two nerves. So there are two nerves that are originating from the trunk, and both of them are coming out of the superior trunk. The first nerve is subclavian nerve. Subclavian nerve supplies the subclavius muscle. That is a very small muscle that is present under the clavicle, and that is why it's called a subclavius muscle. And if I'm not wrong, so it is attaching the clavicle to the first rib, maybe. Okay, I don't remember that completely. But the subclavian nerve is supplying the subclavius muscle, and then there is another nerve that is coming out of the superior trunk. It is called as suprascapular nerve. We have studied about that. So it is supplying the supraspinatus and the infraspinatus muscle. Okay. Then there is no nerve that is originating from these divisions. Then moving to the cords. So from the lateral cord, we have lateral pectoral nerve. The lateral pectoral nerve is going to supply the pectoralis major. The posterior cord is giving rise to three nerves. The first one is, these two stars are for the upper and lower subscapular nerves. The upper and lower subscapular nerves are going to supply the scapularis and the teres major muscle. Remember that subscapularis is going to supply the teres major and subscapularis muscle, and the teres minor is being supplied by the axillary nerve. Okay, so we'll see that when we come here, but remember the thing. Then we have so these two stars are about upper and lower subscapular nerve, and this long nerve, that is thoracodorsal nerve, and this is supplying the latissimus dorsi. Okay, so long thoracic nerve is supplying the serratus anterior muscle, and that is coming from the cord roots, root C6, C7, and C8, and C5 also. While the thoracodorsal nerve is supplying the latissimus dorsi, and that that is coming out from the posterior cord. So I hope you are clear with that. Then from the medial cord, we have medial pectoral nerve that supplies pectoralis major and minor. So from the lateral cord, we had lateral pectoral nerve supplying pectoralis major only, and from the medial cord we have medial pectoral nerve and this one is supplying pectoralis major and minor both. I'm sorry. Then we have medial cutaneous nerve of arm and medial cutaneous nerve of forearm. So they are, I guess, supplying the medial half of the arm and forearm. So remember these nerves as well, and they're coming from the medial cord. Now we are going to talk about the terminal branches. So the terminal branches, so there will be an explanation, I guess there is in this PDF, we have explanation from the Uworld. A very comprehensive explanation is over there for every nerve, like over here, axillary nerve, radial nerve, medial nerve. So we don't need to see the course of them in that. I was going to explain them from the KNM or letter atlas, but I don't think we have a need of that. So remember that the musculocutaneous nerve, I had written somewhere, musculocutaneous, radial nerve, triceps, and gross musculocutaneous. Musculocutaneous normally supplies the bicep brachii muscles. So I had written it somewhere. Now I can't find it. Yep, here it is. So the musculocutaneous nerve, the cutaneous branch to the lateral forearm. So the musculocutaneous nerve provides the cutaneous branch to the lateral forearm, and the motor supplies to the coracobrachialis, biceps, and radialis muscle. Radialis, is that a muscle? I guess it is brachioradialis. Okay, so there are three muscles: coracobrachialis, biceps, and brachioradialis. So these are the three muscles which are being supplied by the musculocutaneous, and the big one is biceps. Remember, the biceps is being supplied by the musculocutaneous nerve, and the cutaneous branch is to the lateral forearm from the musculocutaneous nerve. Then talking about axillary nerve, I guess I had written it somewhere over here. The axillary nerve is, where is axillary nerve? I had written it somewhere and now I can't find it. This is axillary nerve over here. So axillary nerve, the cutaneous branch of the axillary nerve provides posterior and lateral surface of deltoid, and the motor branch is to the deltoid muscle and the teres minor muscle. Remember, the teres major is being supplied by the medial pectoral nerve, not medial pectoral, by the upper and lower subscapular nerve. Okay, I'm sorry. So upper and lower subscapular nerve is supplying the teres major muscle, while the teres minor is being supplied by the axillary nerve. Now we are done with musculocutaneous and axillary nerve. Talking about the radial nerve. So radial nerve is written over here. So the posterior and lateral surface of the upper limb and the dorsal and lateral surface of the hand and pollicis. So basically, almost the posterior surface of the upper limb is being supplied by radial nerve. Okay. Then the muscles which are being supplied by the radial nerve are like a lot of them. It is tricep brachii and coneus, all the muscle of extensor compartment. Basically, remember the radial nerve is supplying all the muscles of the extensor compartment of arm as well as forearm. So these are like brachioradialis. Okay. Then extensor carpi radialis longus, extensor carpi radialis brevis, extensor digitorum, extensor indicis, I guess. Then extensor digitorum, what's that? EDM. Extensor digiti minimi. Okay, yeah, that's extensor digiti minimi. Extensor carpi ulnaris, abductor pollicis longus, extensor pollicis longus and brevis and supinator. I'm very proud of myself that I could break them all. So remember these. So if you are unable to remember these things, remember that all the extensor muscle are being supplied by the radial nerve. Okay, now we go to go. Then we have done axillary nerve and the radial nerve as well. Now talking about the median nerve, so median nerve was written over here. The cutaneous distribution of median nerve is very important. Ventral and dorsal surface of 2/3 of the hand and digit 2, 3. So basically 3.5 digits. The 1, 2, 3. The middle 3.5 digits are being supplied by the median nerve. Yes. So the second, third, and the fourth half digit is being supplied by the median nerve. You'll see that in the picture as well. So it is also going to, it is present in the flexor compartment, and the flexor muscles, the extensor ones were supplied by the radial nerve, while the flexor ones are being supplied by the median nerve. So the pronator teres and quadratus, flexor carpi radialis, palmaris longus, flexor digitorum superficialis, flexor digitorum profundus only the radial half, second and third lumbricals, thenar muscles, which are the muscles of your thumb, then and the muscles which are of the thenar muscle are opponens pollicis brevis, flexor pollicis brevis, and abductor pollicis brevis. Okay. Then talking about the last one, that is ulnar nerve. So ulnar nerve is going to supply these muscles. Ulnar nerve is supplying the cutaneous innervation is to the ventral and dorsal 2/3 of the hand, while this thing. Okay, so I guess it's clear, but if it's not, so let me do that. Yep. So here you can see that the muscle supply of this nerve, that is ulnar nerve, is to the adductor pollicis brevis, ulnar half of the flexor digitorum profundus and flexor carpi ulnaris. So the radial half of the flexor digitorum profundus was supplied by the median nerve, and the ulnar half of the flexor digitorum profundus is now being supplied by the ulnar nerve. Then hypothenar muscles, which are the muscle of your little pinky finger, then opponens digiti minimi, flexor digiti minimi, and the adductor digiti minimi. These are the hypothenar muscles, and this marks the end of our brachial plexus explanation. So I know it's very long, and it is very useless as well, because we are not supposed to remember everything out of that. Remember that there are like roots and trunks, divisions, chords, and terminal branches. Remember the terminal branches only, and remember the branches which are coming out of the root, the dorsoscapular nerve, at least the name of them and the muscle they supply. And I don't think that these are important, like the ones coming from the cord, because they are like intricate knowledge. So the root ones are very important, like the dorsoscapular nerve and the long thoracic nerve. And I think we are good to go with that, but just go through it once and remember as much as you can, and then do the Uworld question, and then you'll be golden. So here you can see that there's the long thoracic nerve coming from root value C5, 6, 7, and here we have the lateral one is giving rise to musculocutaneous nerve. Then we have the ulnar nerve, and both together will give rise to median nerve. Then axillary nerve is over here, and radial nerve is over there. The terminal branches, the terminal nerve, the musculocutaneous nerve coming from the C5 to C6 root value. All the muscle of the anterior compartment of the arm are being supplied by the arm. Remember, arm, not forearm, just the arm. And primary action is flex the elbow and supination, that is biceps brachii muscle. Then the median nerve, it is the site of origin is C5 to T1. Forearm, the muscle innervated by the median nerve in the forearm are anterior compartment except 1.5 muscles by the ulnar nerve, and that 1.5 muscle is, I guess, flexor digitorum profundus. The ulnar half is being supplied by the ulnar nerve. So flexor carpi ulnaris and the ulnar half of the flexor digitorum profundus, that is not being supplied by the median nerve, that is supplied by the ulnar nerve, while the rest are being supplied by the median nerve. So it flexes the wrist and all the digits and pronation. In the hand, the median nerve is supplying the thenar compartment and the central compartment, lumbricals digit 2 and 3. It causes the opposition of thumb and flexes the metacarpophalangeal joint and extends the interphalangeal, proximal interphalangeal and distal interphalangeal joints of the digit 2 and 3. Then we have the ulnar nerve, that is originating from the C8 to T1 root values. The ulnar nerve in the forearm is supplying only to the anterior compartment's 1.5 muscle, which are these muscles like flexor carpi ulnaris and the ulnar half of the flexor digitorum profundus, and the muscles not innervated by the median nerve. So these 1.5 muscles which are not innervated by the median nerve are being innervated by the ulnar nerve. The main supply of the ulnar nerve is inside the hand. So they also exist in the flexion of the wrist and the digit 4 and 5. In the hand, they are supplying the hypothenar compartment, the central compartment including the interossei muscle palmar and dorsal, and the lumbrical digit 4 and 5, and the adductor pollicis. The dorsal, palmar. So the dorsal ones, they abduct the digits 2 to 5, that is dab, and the palmar ones, they adduct the digit, that is 2 to 5, so they are pad. So dab and pad is a good mnemonic. Then the dorsal what? The dorsal lumbricals or the dorsal interosseous? I guess it is about the lumbricals. So the dorsal lumbricals, they are responsible for abduction, while the palmar lumbricals are responsible for the adduction. I may be wrong. I guess it is interosseous or lumbricals. Maybe there is something like that. So is this the lumbricals in metacarpophalangeal flexion and the interphalangeal extension, digits 2 and 5. They flex the metacarpophalanges and extend the proximal interphalangeal joint and the distal interphalangeal joint of the digit 4 and 5. They also adduct the thumb. Axillary nerve, the root value C5 to C6, that innervates the deltoid and the teres minor, that abducts the shoulder 15 degrees to 110 degrees. We are talking about deltoid, because up to 15 degrees it is done by the suprascapular nerve, suprascapularis. Pardon me. It is done by suprascapularis, and that is innervated by the suprascapular nerve. So radial nerve C5 to T1, the posterior compartment muscle of the arm and forearm, they extend the metacarpophalanges, MP, metacarpophalangeal joint, yeah, and then wrist and elbow, supination, supinator muscle. So they help in the supination by the supinator muscle. That is the function of the radial nerve. So this is the picture of, what's that? This is the picture from the first aid. So Randy Travis drinks cold beer. Remember to drink cold beer, whatever, but remember the names like roots, then trunks. These are the trunks, roots, then trunks. Then we have divisions. Then we have what's that? Oh, I'm sorry, I'm so mistaken. So these are the chords. These are the roots over here. Then from the roots, we have these upper, middle, and lower trunks. Okay, which are formed by the fusion of upper one, upper two, lower two, and okay. So these are trunks. Then we have divisions. After the divisions, we have chords, and from the chords we have the branches. So that's it. Okay. So now there are different type of lesions which are associated with different points of on the brachial plexus. Number one, we'll talk about the Erb's palsy or the Vater's tip. Okay. So what is Vater's tip? It is a posture like this one. So what happens in that? There is a damage to the upper trunk. The upper trunk was originating from the C5 to C6. Okay, and that was giving rise to musculocutaneous nerve. Okay, so the traction or tear of the upper or arbor trunk C5 to C6 root causes the infants maybe lateral traction on the neck during delivery, because there was some forced delivery and we were pulling the neck outside, and the angle between the neck and the shoulder was increased. That resulted in the traction or the damage to the upper cords of the brachial plexus. And in the adults during trauma, suppose a person is falling down all the way, like these are the legs of the person and these are the arms extended, and the head just turned so much that the angle between the neck and shoulder was increased dramatically, and that kind of injury in the adults can cause damage to the upper cord of the brachial plexus. Muscle deficit occurs in the deltoid and the supraspinatus muscle. Okay, so deltoid and supraspinatus muscle, the deltoid and supraspinatus muscle, they are being supplied by the axillary nerve, and the supraspinatus is supplying what? The supraspinatus is supplying the is being supplied by the supraspinous nerve. Yes. Then infraspinatus, that is also being supplied by the supraspinous nerve, and then bicep brachii, that is being supplied by the bicep brachii is supplied by the musculocutaneous nerve. So these are the muscles which are damaged. So if the deltoid and supraspinatus are damaged, so the abduction there will be deficit of abduction. Arms will be present to the side. Arm will be severely adducted. Arm will be attached to the trunk. Then lateral rotation of the arm, that is medially rotated. So lateral rotation is not taking place, so the arm will be medially rotated. That was the function of infraspinatus, to laterally rotate the arm. If infraspinatus is not functioning properly, so the arm will be medially rotated. And the bicep brachii, that was supposed to do the flexion and supination, so the arm will be extended and pronated. As you can see, the arm is extended and also pronated. So this is the Erb's palsy that is caused due to the or the Vater's tip that is caused due to the damage to the upper cords of the brachial plexus. Then we have Klumpke's palsy, that is traction to the lower trunks. So we saw the damage to these two roots. Now we are going to see the damage to these two roots. So if there is damage over here in the lower trunks, so what happens? The CA to T1 root, the infant's upward force on the arm during delivery. We are pulling the arm of the infant during the delivery, so that can cause Klumpke's paralysis. Or in adults, trauma, for example, grabbing a tree branch from a to break a fall. So a person was sitting on the tree and then he started falling. So to break the fall, he held on some tree branch, and now his body is falling downwards while he is his arm is holding the tree branch, so there is a rapid or shear stress that is caused by that pull, and that pull can damage the lower roots or the lower trunks of the brachial plexus. The muscles which are being damaged are intrinsic hand muscles, the brachial, interossei, thenar and hypothenar muscles, and the resultant is total claw hand, or that is also called as ulnar claw hand, because we know the ulnar nerve is originating from here, so ulnar nerve deficits will be seen along with some median nerve deficits. So total claw hand, lumbricals normally flex the metacarpophalangeal joints and extend the distal interphalangeal joints and PIP joints. So this was a function of lumbricals, but in the case they are gone, so the person will develop ulnar claw hand. Okay, that can be partial or complete. Like partial will involve these two fingers only, and complete can be like that. So this is the ulnar claw hand. Then thoracic outlet syndrome we will discuss from here onward in the next session. Until then, Allah Hafiz and Fi Amanillah.